Waiting for it to say started. And we're live.
Hey.
Hello, everybody. Welcome back to our Menopause 201 series. I am Dr. Rebecca Dunsmoor-Su. I'm the Chief Medical Officer here at Genève. I am a board certified OBGYN and menopause practitioner. And I often host these, but we put them on every month to sort of go over more in-depth topics in menopause care. And today I am super excited because we have a guest who I've known for many, many years and have really been a fan of for many years. Dr. Sarah Speck is with us, and I'm going to let her introduce herself. But just so you guys know, I've worked with her for many years in various different ways, both at Genève, at Swedish Medical Center here in Seattle. And I just have the utmost respect for her knowledge base and how she brings a holistic look towards women's cardiology. So, Sarah, please take it away. Tell us all about yourself.
Oh, thank you so much for that kind introduction, Rebecca. I'm very pleased to be here tonight. I'm really, as you can see, a menopausal woman, so really interested in this topic. Um, I've had the privilege of being the director of cardiac rehabilitation at Swedish Medical Center for a couple of decades, actually, and have seen many women come in having already had an event. And so we've grown over the years, and fortunately in our knowledge. And I think what's so gratifying is that we now know there are some things that we can do to prevent that. And hormone replacement therapy is kind of right in the middle of that and a growing field. So I'm really pleased that all of you are here to discuss more about it. I can't say that we know all the answers because we don't, but we certainly know a lot more than we did a couple of decades ago. So thank you for having me tonight.
Yeah. So, we're talking specifically about cardiovascular health and women tonight. And I think, obviously it's February, it's Heart Health Month. It's a timely topic. But in my mind, this is a topic we should be talking about every month. I'm sure it's that way in your mind as well, Sarah.
Yes.
Um, but I think it helps to sort of start by centering on like what is the cardiovascular risk that women face over their lifetime? Is this an important risk and why should we be talking about it?
Well, as all of us know who are on this call, heart
Mhm.
disease remains the greatest risk of dying in the United States, both for men and for women. And in fact, more women die of heart disease every year than men do.
Mhm.
Um, and I think if you remember nothing else from this call tonight, this discussion, it is the statistic that by age 45, 1 in 9 women have declared heart disease. And by age 65, 1 in 3.
Yeah.
So again, we have a tremendous opportunity during the perimenopause and menopause years to affect that statistic. We catch up with men at age 80 when, again, it's 1 to 2. And I would say the comparative statistics with men are 1 in 5 at age 45 and 1 in 2 at age 65. But
Mm.
we want to really stop that for women, and we can do it.
Yeah. And I think that's really important. I think, many of us who trained perhaps 20 or more years ago, um, heart disease was really thought about as a man's disease because we saw it in younger men and women were older when it presented. But it really is a disease that women face, and a lot of women don't know about it. And I think that's the biggest thing. It's one of the conversations I have with my patients every single day when they're like, oh my God, I don't know if I can use hormones because of the breast cancer risk. I'm like, if you get breast cancer, you will most likely live long enough to die of a heart attack. So let's talk
Exactly.
about your heart.
Exactly. Exactly. I mean, women have different presentations. They have unique risk factors, and hopefully we can delve into more of that. But still, women have the big five, just like men do in developing heart disease. And what the heart disease we're talking about is that which clogs up your arteries.
Right.
Basically, this is atherosclerotic plaque. It can begin as early as 2 or 3 decades of life. It can be, and it can progress depending on how many risk factors you accumulate. And the
Hmm.
big five basically are diabetes, smoking, hypertension, being overweight, and having a high cholesterol or an abnormal cholesterol lipid profile.
Right.
And those are just as prevalent in women as they are in men, and just as preventable, frankly.
Right. Yeah, and I think that's another great point you bring up, and we'll talk a little bit about some of those preventative measures as we get into the conversation. But I think there's a narrative out there that we need to bust, that the medications for cholesterol, the medications for hypertension have all been studied in men, but we don't know if they're good for women. That's not true.
Correct.
These work in women, right?
Absolutely.
So absolutely something we should be talking about with women. I usually like to start the conversation by saying, well, why is this a menopause topic? Like, what is the role of estrogen in all this? Because I think people are more and more savvy nowadays. They're like, oh, estrogen's so protective for my heart, so I'm not going to get heart disease until I'm menopausal, which isn't entirely true. You've already told us that.
Mhm.
But we do see a sudden increase as women go through the menopausal transition. And, estrogen definitely has some properties of being an anti-inflammatory, which may be protecting our blood vessels from building plaque. Um, and, I think there's a lot of chatter about menopausal hormone therapy being protective for cardiovascular health. And it's something I think we should both sort of give our impression of.
Mhm.
There's a lot of great data that says that. I look back to studies like the Framingham study, Nurses Health study, even the WHI, if you split it out by age groups,
Yes.
which tell us that conjugated equine estrogens are protective for the heart. But where and I struggle in counseling my patients and talking to other physicians, is that we don't have a lot of data on transdermal estradiol, which is our primary mode of giving hormone replacement therapy now. And there may be a difference between getting it through the skin and taking it orally, and there may be a difference between those two products. How do you sort of address that idea, or do you talk about it?
Oh, we certainly do talk about it. I think,
Yeah.
again, menopause is a time of transition, not only for your arteries, but
Hmm.
obviously for those other risk factors. I mean, the belly fat that can lead to insulin resistance,
Hmm.
prediabetes, and diabetes increases the risk of heart disease 4 times it does for women, as opposed to two
Right.
times for men.
Hmm.
Um, there's a development of hypertension. 50% of women develop high blood pressure at age 50, 60% at 60, 70% at
Yeah.
70. So clearly there's a role of estrogen withdrawal, if you will, in the
Hmm.
development of that major cardiovascular risk factor. The dyslipidemia, quote unquote, the elevated
Hmm.
LDL, lousy cholesterol, lower HDL, healthy cholesterol, higher triglycerides, all of these happen with estrogen, quote, deprivation or estrogen
Right.
withdrawal of menopause. So these things are clearly factoring into your global cardiovascular risk profile.
Right.
And that's the conversation I have with women. In
Hmm.
other words, yes, the American Heart Association, the American College of Cardiology have not embraced giving hormone replacement therapy for the prevention of heart disease. But that doesn't mean it doesn't work, because we know
Right.
from the studies. But it does mean that you got to pay attention to these other global cardiovascular risk
Right.
factors. And that's the conversation I have with women.
Yeah, and we do know that menopausal hormone therapy can impact those things. It may not be by a lot. Like, it certainly doesn't raise blood pressure. We often think of hormones as raising blood pressure, but that's true of ethinyl estradiol in a birth control pill. Even then, it's only by a couple of millimeters of mercury.
Right.
But it's not true of menopausal hormone therapy. It definitely does lower cholesterol profiles, not by a lot. Again, but again, all of these studies are population based, right? So on
Correct.
average, you
Correct.
see maybe 5 or 10 points lower, but in an individual person, that may be more.
Correct.
And even 10 points is probably beneficial in
Absolutely.
that sense. But you mentioned diabetes, and I'm so glad you brought it up, because I think one thing that many people don't know is, even physicians, because it's sort of been buried in the headlines of everything else that came out of the WHI and other studies, is that if we look at women who are at higher risk for diabetes, so those who are pre-diabetic, those who have metabolic syndrome or polycystic ovarian syndrome, using menopausal hormone therapy lowers their risk of developing full-blown diabetes by somewhere between 19 and 30%,
Correct. Correct.
as long as they use it.
Yes.
Once they come off, then their risk goes up. But that's level one evidence. This is randomized control trial evidence. We know this helps to prevent diabetes, and that is a huge risk factor. So I'm really glad
Exactly.
you brought that up.
Exactly. And the question of whether or not you use oral, or whether you
Yeah.
excuse me, whether you use transdermal, I think is, again, somewhat individualized. And I think
Yeah.
it depends on where you're starting from.
Hmm.
And again, it's not menopausal hormone replacement therapy is not a panacea. If you
No.
have elevated cholesterol, statins plus MRT are important.
Right.
If you have diabetes, GLP-1 plus, or
Right.
obesity, GLP-1s are important plus menopausal
Right.
replacement therapy. And the idea in my mind is to optimize as much as you can.
Yeah. No, I think that's a great point. And I think we all of us on this call see patients who come in, they're like, I don't want to take all those other medicines. I just want the hormones. And I tell them the hormones can only do so much. You have demonstrated a risk factor. We should be treating that risk factor. I talk more women into statins, I think, than I do into menopausal hormone therapy. When they come to me, they're like, my cholesterol's 220 and I need hormones. I'm like, no, you need a statin. I can give you hormones. They're great.
Right.
You need a statin. So, talking about women and heart disease, I do want to spend a little time on how do women present with heart disease? Because I think, sometimes we have a classic picture of the crushing substernal chest pain, elephant on the chest, like this is what a heart attack looks like.
Mhm.
And there is some narrative now that women may not present in that way, and they may not present with the same types of cardiovascular disease that men necessarily do at the same age. Is that correct?
Absolutely. Again, I think what you want to start out with when you're in menopause
Hmm.
or well, a bit before, is what is your risk profile? What
Right.
are your risk factors? And in addition to the big five that I talked about, women are more at risk if they have autoimmune disease, which we know
Mm.
happens more often in women.
Yep.
They're more at risk if they had preeclampsia or
Hmm.
diabetes associated with pregnancy. Even if they don't have hypertension or diabetes at the present time, they are more at risk if they have significant psychosocial stress. And your daughter just
Hmm.
decided that she's going to get divorced, or
Right.
something. And these factors actually do play a role not only in chronic development of atherosclerotic plaque, but also the acute presentation. So
Mm.
when you ask me how women present, um, women can certainly have the elephant sitting on the chest,
Right.
but they can also have. I've met women in the emergency room who swear if they just burp, they would feel better, and they're having
Right.
an inferior myocardial infarction.
Hmm.
So, if you have those risk factors and you have unusual shortness of breath or unusual discomfort in your arm, your jaw, your back, or unusual nausea or palpitations that are making you lightheaded, think heart disease.
Right.
Don't call your son, call 911.
Yeah. Exactly. Exactly. And one other risk factor that you didn't mention is women who have more vasomotor symptoms have a higher risk
Exactly.
of cardiovascular
They
disease.
are
And it may not be causative necessarily, but it's certainly
associative.
associated.
It's
Yeah.
associated, exactly.
Yeah.
And I would also say that there's very well documented heart
Mm.
disease that's associated with significant in the moment psychosocial stress. We know
Mm.
that the quote unquote broken heart syndrome is something that women develop acute congestive heart failure, which
Wow.
is which again is associated with significant stress. I've had women who are visiting their husbands in the hospital and have a heart attack in front of my very eyes. Uh,
Mm.
and we also know that women can have what we call microvascular disease, and that
Yeah.
is maybe they only have a 30% narrowing in their epicardial blood vessels, and that chest pain gets dismissed in the emergency room or because when they have an angiogram, oh, it's not really real, it must be your esophagus, when in fact those small blood vessels that are embedded in the myocardium are either spasming or having some atherosclerotic plaque, which we can't demonstrate with our current techniques.
That's really interesting. And I think that leads me on to a question I was actually going to ask you later, but I'd love to talk about now, which is cardiac calcium scoring, because I think that looks more at the bigger vessels, doesn't it?
That's right.
Not so much at the microvascular disease.
Exactly. I like cardiac calcification in epicardial blood vessels is atherosclerosis, period, end. There
Mm-hmm.
are no false negatives. There are no
Mm-hmm.
false positives.
Right.
That's what you've got.
Right.
And if your score is less than 100, it's likely not associated with any soft plaque that's actually occluding the disease or going to cause ischemia downstream. If it's greater than 400, then we need to have a different conversation.
Right.
But if it's less, even if it's less than 100, even if it's 50, you've
Mm-hmm.
got atherosclerosis. And
Right.
that's a discussion that we need to talk about when you consider hormone replacement therapy.
Right. And do you look at the scores that women get around the time of menopause differently than, say, a 45 or 50-year-old man's score? Like, should women still be at 0 at 45? Or, like, is there a difference in how we interpret that? Or is it the same across all comers?
Atherosclerotic plaque in your arteries, whether or not it calcifies, is kind of like the plaque on your teeth. You know, you can
Mm-hmm.
floss away the stuff, the soft stuff between cleanings,
Mm-hmm.
but eventually the hygienist is going to find some hard stuff that she needs to take away.
Mm-hmm.
Um, Pre-menopause, women may not calcify their plaque.
Oh, interesting. Okay.
So when you talk about a 45-year-old man versus a 45-year-old woman, a 45-year-old man may have calcified plaque, a 45-year-old woman may have soft plaque, which is not yet calcified. And
Mm-hmm.
that's where another screening test comes in, which is called a carotid IMT ultrasound.
Oh,
And what that
okay.
is basically, because the carotid artery obviously is so close to the surface, we can image it quite nicely with ultrasound, and we can see not only whether there's calcified plaque, but also soft plaque there. We can
Mm-hmm.
also see whether or not there's thickening of the artery wall, because we know that this is a disease of arterial inflammation. And so looking at markers like high sensitivity C-reactive protein in the bloodstream to predict whether or not you've got atherosclerotic milieu, if you will. But we can also look at actually the anatomy of it by
Mm-hmm.
looking at this carotid IMT score. And that is often positive in women who are at risk when they are
Mm-hmm.
premenopausal or perimenopausal.
Oh, that's interesting. That's really good to know because I think sometimes we just sort of think women aren't at risk until they get through
Yeah,
menopause, but it's not
yeah,
true. They're still at risk.
right.
We
And
just don't see the
there
same
was actually
findings.
I'm sorry, there was actually a
Yeah.
nice trial called the ELITE trial that looked
Hmm.
at the effect of or hormone replacement therapy in about 700 women, and they followed them, the carotid
Oh.
thickening, and basically they didn't see any significant deterioration or quote change that was
Hmm.
progression. So again, another what do I want, flag saying, yes, we should be considering menopausal replacement therapy for cardiovascular prevention.
Well, that brings up a really good point because I think often, like, if you read some of the recommendations from the Menopause Society, if you look at some of the, well, I don't look as much at the cardiovascular recommendations because I think they're in a different place with menopausal hormone therapy than even the Menopause Society is.
Mhm.
But a lot of times they're saying, this, we can't really counsel on it being a preventative, but, you should be calculating a risk score or considering whether a woman is at risk before starting her on menopausal hormone therapy. So some people choose to use like an ASCVD calculator to say, oh, your risk is high. We shouldn't start it because you might be at higher risk for putting a blood clot on your plaque that's already developed. But you're saying even with someone who may have some risk factors, who's on that pathway, it may still have protective benefit.
I would say definitely in women who have what we call subclinical disease,
Mm-hmm.
who have not yet had an event, that
Mm-hmm.
that is a consideration, yes. That we
Okay.
should we shouldn't throw the baby out with the bathwater here.
It's hard. I think there's a lot of people who throw the baby out with the bathwater when it comes to menopausal hormone therapy. They're scared of it. Like we've been told to be scared of it for the last 30 years.
Right.
And now we have to sort of claw our way back from that. Um,
I would ask you a question, and that
yeah,
is,
sure.
what are your thoughts about women who've had a remote DVT and
Ah,
now are searching for menopausal
right.
replacement therapy?
That's a really good question. And I actually just spent some time with the literature and the recommendations on this because it
Mhm,
comes up a lot.
mhm.
And there are Instagram voices and TikTok voices who say, no, it's fine as long as it was a provoked DVT or you should be fine. So I looked at the literature and we have a good deal of literature showing that transdermal estrogen, especially at a 0.05 patch or below,
Mhm.
does not increase the risk of blood clotting. So they on huge population-based studies, no increased risk of blood clot. But I'm going to qualify that in entirely low risk women.
Mhm.
So everyone in these studies had never had a blood clot and had no clotting factor, heterozygous or homozygous changes. I can't really apply that data to someone who's had a clot. So I tell my patients, if they've had a provoked DVT, and what I mean by provoked is I broke my femur and was immobilized for 8 weeks,
Mhm.
provoked DVT. it's a risk benefit discussion based on
Mhm.
all of their risk factors and all of the benefits they might get. And we might consider using it at transdermal at 0.05 or below. The Global Endocrine Society says people who are heterozygous but have no family history of clotting and no personal history of clotting, they just know this for whatever reason, it's probably safe to use transdermal at those levels and below.
Okay.
If someone has had a blood clot while they were on birth control pills, it's a hard no for me.
Mm,
They've proven their ability to clot with estrogen. I had one
mhm,
patient said, no, it was provoked. It was in pregnancy. I'm like, yeah, that would be a high estrogen state.
mhm,
I'm not really feeling like I want to put estrogen back into the system
mhm.
because then you're just at higher risk. And in my mind, a DVT and then a PE is just so much higher risk. And there's so many things we can do to
Right,
manage symptoms
right,
and prevent cardiovascular disease and manage your bone health that don't involve that estrogen.
right.
So that's how I approach the clot issue. It's tough. It's subtle. But I have a lot of patients who come to me who say, "No, I've heard that transdermal estrogen doesn't increase clot risk." And I say, "Yeah, in low risk women, you're not low risk anymore."
Right.
And certainly if someone's had, like I have one patient in my panel right now who had like a retinal clot. I'm like, "Oh
Mm.
no."
Yeah, yeah, yeah. Right.
Zero chance we are starting estrogen with
Right, right, right.
you.
And from a cardiovascular standpoint, obviously, there are other drugs that we can use to
Right.
reduce your risk for those reasons. Yeah.
Exactly. Exactly. It gets more complicated if they're actually on anticoagulation for some reason, or on Plavix, or on,
Mhm,
all these
mhm.
things balance. So it can be a somewhat individualized discussion, but it's a tough one because they're hearing out there that it's perfectly safe. And I have to step them back and say, well, nothing's perfectly safe. But yeah. So in your practice, like what are the big things you look at to assess a woman's risk? You already talked about some of the risk factors that you're looking at, but what is your usual panel of, say, testing and assessments, and like what should every woman at 45 or 50 have done to understand her cardiovascular risk?
So I think obviously a good history, right? I
Yeah,
mean, if your dad died at age 52 of a myocardial infarction, then I'm interested, very interested in what your genetic profile looks like. And
right.
that to me means looking at your lipoprotein A.
Hmm.
Uh, Actually, the European Society of Cardiology recommends that all adults over the age of 21 have a lipoprotein A
Oh.
screened.
Hmm.
It is a genetic, it's a phenotype of an abnormal genetic variation. But basically, what it does, and again, I like simple analogies. It puts a corkscrew on that LDL particle and really makes it very aggressive in forming plaque.
Mm.
And if you have an LDL, if you have lipoprotein A, we want to look very aggressively for you having any atherosclerotic disease.
Mm.
And we want to do those two screening tests, either a coronary calcium scat or a carotid IMT that I talked about. There's also another screening test that's called apolipoprotein E or ApoE.
Hmm.
And if you have a 4 in there, you have a 40% increase independently of any other risk factors of developing heart disease in your lifetime.
Wow.
You also, unfortunately, have a risk of developing Alzheimer's type dementia.
Right.
But the good news about that is you can really alter your cholesterol profile and your risk by altering your diet, by becoming a vegan or almost complete vegan with very low fat in your diet.
Mm.
So those are the two genetics that I really hang my hat on for people if they
Hmm.
come and tell me that. Then I look at what is your LDL profile. I look at what's your blood pressure. Now,
Right.
120 over 80 is the peak of normal blood pressure, not
Right.
130 over 80. So if
Right.
you're walking into my office at 128 over 78, you have borderline hypertension, and I want to know about that for you. Then I take a pretty good clear history of how are you moving? Tell me
Right.
what you do for movement. Tell
Right.
me, because sedentary really is sitting is the new smoking in terms
Hmm.
of the risk factors for women and for men, obviously, but particularly for women. And the other is tell me what you eat. You know, do you eat every day? What's your breakfast, lunch, dinner look like? So I'm looking at that whole profile to basically say there are a lot of things that we can do with lifestyle here, in addition to what I may recommend for medication for you going
Right.
forward. So I'm taking that history, I'm looking at those basic vital signs, and I do think that exercise is a vital sign.
Mm-hmm.
Um, and I am looking for some evidence of subclinical cardiac disease, atherosclerosis.
Mm-hmm. Yeah, I think there are so many recommendations out there, whether you look at US Preventative Task Force versus ACOG versus the cardiology associations, about how often should we screen for a lipid panel? How often should we screen for diabetes in women as they age? You know, I see no harm in doing it every year, especially if someone has risks. But
Yes.
I know that not all insurances agree with me. Is there a pattern for your general, not someone who has higher risks, not someone who already has known disease, but your general lower risk woman as she's progressing through the menopausal transition? How often would you screen those things?
I would screen them on an annual basis. I would
Okay.
get a general lipid profile. I would get a high sensitivity C-reactive protein.
Mm-hmm.
This is a protein that is reduced when there is endothelial inflammation present,
Mm,
and it needs to be tested in an environment where you didn't just get a recent vaccine or you just haven't had a cold, because
mm-hmm.
that kind of general inflammation will increase the level falsely. But a level over 3 is very predictive of a cardiovascular event in the next 5 years.
That's actually really interesting because that's not one as an OBGYN, I
Right,
think, to test.
right. But
Yeah.
again, I mean, I think these, yes, they may not be paid for by insurance company, and I don't mean to say that everyone can
Mm.
afford it, but it's about the expense of a nice, it's about the same expense as a nice dinner. And I
Mm-hmm.
think that you can invest that for yourself.
Yeah. No, that's a great point. It's often what I tell my patients about a cardiac calcium score because they're almost never covered by insurance,
Right,
correct?
right.
And but they're not very expensive. I know in our region, 100 and some dollars to get
Right.
that done.
So,
And it
right, I'm sorry. Go
Go
ahead.
ahead.
So a coronary calcium score, if it's 0, I would get it repeated in 5 years.
Okay.
If it's 50 or less, I'd probably do it in 3 years. If it's higher than that, I would treat you obviously aggressively, and probably get it again in another 2 years to kind of follow along our progress.
That's great. Yeah, I think that's, there's some things in there that most of us as OBGYNs and many of the people on the call will be OBGYNs just don't think to check. These are, even if we're trying to keep up, things move rapidly. When I was in medical school, it was, oh, you just get lipids and treat if they're way up here. And things have really changed.
Exactly.
Yeah.
Exactly.
So I know a large part of your practice focuses on using exercise and lifestyle as medicine. So I'd
Correct.
love if you talk to us a little bit about like what are some of the general recommendations that you make to women for cardiovascular health in terms of how they move, how often they move, but also how they eat. Like there are all these diets out there that we're told are good. There's the DASH diet, there's the Mediterranean diet, there's intermittent fasting, there's all these things. And women are inundated with diets both for weight loss and for health.
Right.
How do you counsel women on those things?
Again, I try and take a pretty careful dietary history. I think that let's talk for women who
Hmm.
are not obese, but we're
Right.
not necessarily speaking about weight reduction per se. Atherosclerosis is a disease of inflammation of the endothelial surface.
Hmm.
And what we know is pro-inflammatory is a ribeye. What we know is anti-inflammatory are plant-based foods.
Hmm.
The nutrition in plant-based foods, by virtue of them being plant-based, is anti-inflammatory. So basically what I tell people is try to be a vegetarian twice a day and eat the Mediterranean diet when you share your dinner with your family. The
Hmm.
Mediterranean diet, by virtue of looking at lower saturated fat to protein ratio in chicken, turkey, and fish,
Hmm.
is anti-inflammatory. It has plenty of protein. It embraces 10 servings of vegetables and fruit in combination every day. A serving is a half a cup. So if you focus on it, it's not too hard to get it here in the Pacific Northwest.
Hmm.
It has been shown to reduce the incidence of diabetes, to reduce the cholesterol readings. It's been shown within 6 months of people who've already had an MI to reduce their risk of having a second myocardial infarction.
Okay.
So that's pretty much my go-to.
Mhm.
Again, for people who have ApoE4, and we know that even fish oil, they can take that and convert it into LDL cholesterol. We really try and limit the total amount of fat calories they have to less than 20% daily.
Wow.
And to choose those wisely. And I have a great nutritionist who works with me, and I
Hmm.
usually ask them to meet with her, so she has
Hmm.
some great ideas of appropriate substitutions. Um, in terms of exercise, anything that moves the big muscles between your waist and your knees for 150 minutes a week is beneficial for reducing inflammation and reducing your cardiovascular risk. In my practice, we often recommend that people come in for what we call a body fuel profile.
Hmm.
And what we do is a metabolic rate at rest to tell us how many calories do your liver, your lungs, your kidney, your brain, your vital organs need every day to survive. And we try and formulate a calorie balanced meals plan for them using that.
Hmm.
And then we do a VO2 max, and a VO2 max basically is a ramping protocol treadmill where you wear a mask that captures all your inspired oxygen and expired carbon dioxide. And we look at that ratio and plot it against their heart rate. And we can tell at exactly what heart rate range they're burning fat as fuel versus when they switch over to using carbohydrates. And when you're trying to improve your insulin resistance, your pre-diabetes, your real diabetes, when you're trying to lower your LDL production, you want to be a very efficient fat burner. So by looking at that zone, which is quote unquote zone 2, and knowing what it is and getting something that can track your heart rate, in 6 months, you can make a significant impact on not only your endothelial health, but also your biochemical parameters.
Very nice. That's a lot more
It's
than I usually
exciting.
give
It's
women.
exciting.
And one of the things, I'm glad you mentioned protein because I think, plant-based, we all know that plant-based diets are probably the healthiest.
Mhm.
But one of the things we struggle with balancing with that is in menopause, as women are going through the menopausal transition, even if they're taking estrogen, building and maintaining muscle is really critical for a lot of reasons, both for weight management, weight maintenance, but also for protecting bone and preventing falls and all of these things that become bigger issues as we age. And I think getting enough protein in a plant-based diet can seem daunting to people.
I
So
agree.
adding that sort of Mediterranean meal once a day may really sort of balance that. And, I think there is a role definitely for people being entirely plant-based, but it's not for many of the patients who come and see me and who see our registered dietitians at Genève, it's just not something they can commit to. So having
Exactly.
options
Exactly.
is
Exactly.
is really important. I have been sort of half-heartedly watching the chat as we talk and haven't seen any questions come up, but I want to sort of ping our listeners to say, hey, we're sort of getting to the end of our talking points. I'd love it if people have questions, if they start to put them into the chat so that we can ask them and address them, because I want to make sure that we get to all of those. Um, is there anything else that I haven't asked you that you really want to emphasize for us in terms of what do we need to be saying to menopausal women about their heart health, or what's something that we as, internal medicine doctors, OBGYNs, family practitioners can be doing to make sure we're helping women recognize the importance of maintaining heart health?
Well, I think health is something that we take for granted.
Mm-hmm.
um, and I think that, again, menopause is an opportunity to really look at all aspects of your health. And it's calls you into the
Mm-hmm.
physician's office primarily because of vasomotor symptoms. But that's the time when to know what your blood pressure is, to know
Right.
what your blood sugar is, to know what your LDL cholesterol is. If you can start addressing those aggressively, it will make you so much more healthy in the next
Mm-hmm.
1/3 of your life.
All right.
And I
So a
and
couple.
I
Mm-hmm.
think if we can partner OBGYNs, cardiologists, internal medicine, primary care doctors to emphasize that to women, that
Mm-hmm.
as we're treating your obvious symptoms to make you more comfortable, we're also taking this opportunity to improve your overall health.
That's an excellent point. So we do have a couple questions. The first
Right.
one is, so at what LDL level do we start treating in women?
So all of us should be walking around with an LDL of 100 milligrams percent or less.
Okay.
If you've already had a cardiovascular event, the new recommendations are that your LDL cholesterol be less than 55 milligrams percent.
Wow.
Very difficult to get there, even with a vegan diet. So it
Mm-hmm.
usually requires some statins.
Mm-hmm.
If you have an LDL cholesterol greater than 190, you most likely have a genetic condition called familial hypercholesterolemia, and it's impossible, even with diet and exercise, to move the needle on that.
Mm-hmm.
Most people have a genetic deficiency of production, so they do well with starting statin therapy to get them down to 100 milligrams percent.
Mm-hmm.
Other people require what's called a PCKS9 inhibitor, which enhances clearance of LDL cholesterol because their defect is it's not that they make too much, they just never get rid of it.
Mm-hmm.
So if you, in my own bias, if you have a coronary artery calcium score greater than 300, we should be treating your LDL cholesterol more aggressively and getting it down to 70 milligrams percent.
Oh, okay. That's really good to know. Because I think some people are thinking, oh, well, if I'm under 200, if there are all these sort of myths out there, but we
Right.
really do need to be pretty aggressive with this.
I
Um,
think the other thing I would say is that
mhm.
the HDL to LDL ratio is nice for population work, but it really
Mhm.
doesn't matter to that person sitting in front
Ah,
of you. HDL is like the Swiffer. It picks up the dust bunnies, but it
mhm.
doesn't keep them from being laid down. So you really need to concentrate on that LDL.
Okay, that's actually a really good point because I think often people focus like, oh, I have a high LDL, but I have a really good HDL. It's like, yeah, but you still have a high LDL.
Right, right.
If someone has autoimmune disease or celiac disease, increased risk of type 1 diabetes, is something like that associated with cardiovascular disease?
Some of the time it is. I
Mm-hmm.
would say, type 1 diabetes, particularly if it's type 1.5, is more
Mm-hmm.
associated with it. Celiac disease, not so much, but other autoimmune disease, rheumatoid arthritis, psoriatic arthritis, lupus, yes, definitely.
Okay. Yeah. I mean, lupus, I think as physicians, we all know that's the case because of, if nothing else, the clot risk that comes along with it. But it's good to think about rheumatoid arthritis and psoriatic arthritis as well.
And again,
Um,
HSCRP can help you there. That cardiac
mhm.
CRP can help you to see
Oh,
whether or not that patient really does have endothelial inflammation.
oh, that's actually a good point. Thank you. Um, so here's another question. Do you treat an elevated APO, it says ApoB, but I'm not sure if it's ApoE, as aggressively as we would treat an elevated LDL?
So ApoB is what I think this person
Okay, I
means.
don't know
ApoB,
ApoB.
yeah. ApoB basically represents all of the particles that could possibly cause atherosclerosis.
Ah, okay.
And in most individuals who do not have diabetes and don't have high triglycerides, 95% of that ApoB is represented as LDL and LDL
Hmm.
particles.
Okay.
So the it's basically work on the LDL and then work on the LDL particles or the ApoB, because ApoB is what carries the cholesterol through the system and takes it where it's supposed to go, but unfortunately where it's not supposed to go.
Mm,
And so even though each particle may be carrying less cholesterol per particle, more particles mean more entry points into the intimal space and more atherosclerosis.
right. So there's one for me, which is how do you quote the risk of thrombosis DVT with an estradiol patch for low risk women? I sort of hinted at this when I talked about the studies. What I tell my patients is that in large population-based studies, they have shown that an estradiol patch of 0.05 or below does neither increases clotting factors detectably, and they do not see any increased risk in thrombosis over the baseline rate. And I also tell women that actually there are some pretty good big studies that show either transdermal or oral, if you're under the age of 60, really, as long as it's estradiol, don't really increase your clot risk. That being said, there's a big black box warning on the estrogen you're about to prescribe them that
Yes.
says it's going to cause them a clot. So I tell them, while we have these studies that tell us this, we also understand that even the estradiol that your body made puts you at higher risk of blood clotting than someone who doesn't have that level of estradiol. So it's a bit of a subtle discussion. So I can't ever say that there's no risk, but we think that there's very little risk in that transdermal under a 0.05 or in someone who's under 60 using estradiol of any form. Do statins reduce risk of MACE in women as much as men?
They do. MACE are major adverse cardiac events.
Mm-hmm.
And yes, the studies have shown that statins reduce the risk by 40 to 50% as effectively in women as they do in men.
Yeah, that's a really great point. I'm glad somebody asked it because I think a lot of our patients have the impression that statins work in men, but they don't work in women, but they
Right.
absolutely work in women.
Right.
What are your thoughts about the utility of the ASCVD risk tool?
The ASCVD risk tool has gotten a lot of bad press for women. I don't think again, we should throw the baby out with the bathwater, but I think we need to realize that it does not include high sensitivity C-reactive protein, i.e.
Mhm,
the effect of any autoimmune problems that women may have. It's heavily weighted to diabetes, which many women have. It's also heavily weighted to age.
mm,
So again, I think if a woman comes in with me to me and has an intermediate, like 7% ASCVD risk profile, and they don't want to take statins or they've been recommended to take statins, I look for subclinical disease. That's when I
mhm,
pull out my coronary artery calcium card or my carotid IMT and I say, let's see. I mean, cholesterol's a number. High
mhm.
blood pressure should be treated, but cholesterol is just a number. Let's see if you've got any plaque.
Thank you. And then question, sort of a clinical scenario. How would you counsel a young-ish woman, say 23 years old, who has a lipoprotein A of 180 and ApoB of 100?
I would counsel them to eat a Mediterranean, largely plant-based diet. I would put them on an exercise program. And at age, and I may go ahead and get an apolipoprotein E, not B,
Hmm.
but E on them to see if they have any other genetic risk factor that we need to address. And then I would be aggressive at looking for subclinical plaque. So at age
Hmm.
30, I'd get a carotid scan on them and see if they've developed anything in the interim.
Yeah. Yeah. And I think these are the people who have those early heart attacks as women that we just don't catch, right? Because we're not looking for it in young women. Um, we have a layperson question. How do you advise patients to advocate for themselves if they're concerned about cardiac symptoms and are worried about being dismissed for anxiety? Can you imagine a woman being dismissed as hysterical or having anxiety?
Can't imagine that.
Can't
Uh,
imagine. Yeah.
um, well, first of all, I think you have to find a provider that doesn't dismiss you. I mean, if you go to the emergency room and you have chest pain
Hmm.
and they tell you that it's nothing, then you need to find another provider who will listen to your concerns and do a systematic review of what it could be.
Hmm.
Um, I think that, again, knowing your numbers at 30, blood pressure, cholesterol, diabetes, whether or not you smoke, whether or not you're at an ideal weight. These are all things that are going to go into that equation to try and figure out, is it esophageal spasm? Is it anxiety? Is it atrial fibrillation?
Right.
Or is it coronary problem?
Yeah, no, that's a really good point. And I think I'll add one more. Is it the palpitations of perimenopause?
Right.
And,
Exactly.
I tell all of my patients, and they're like, oh, it's heart palpitations, but I've read that could just be perimenopause. I'm like, it could just be perimenopause, or it could be something else. You deserve an EKG. It's not that hard.
Right. Right. And it's not that expensive.
And it's
Even
not
if
that expensive.
exactly.
Let's rule
Yeah.
out the bad things and then we can
Right.
treat the perimenopause. Um,
If I can just add one thing about
yeah.
palpitations, and that is, palpitations can occur because all of us have extra locations of electrical activity that can be pinged
Hmm.
when we have any kind of imbalance, whether we're stressed or we haven't slept well, or we've had too much alcohol or too
Hmm.
little alcohol or too much caffeine or too much sugar or perimenopause or pregnancy. Um, but palpitations that are associated with shortness of breath, with breaking out in a cold sweat, with feeling some discomfort in your chest, these are something to pay attention to and not just to dismiss. And
Right.
if your provider doesn't pay attention, find another one.
Yep. I agree with that. If no other risk factors and an LDL greater than 100, would you check a CRP and ApoE before starting a statin or only for patients with other risk factors or strong family history?
Um, If an LDL is greater than 100 and the patient has no evidence of subclinical coronary disease, then I would work with them with lifestyle measures and not necessarily start a statin. My threshold for starting a statin is about 160 milligrams percent, but maybe 150, 160 milligrams percent, because even with diet and exercise, it's really difficult to lower it by more than about 30%.
Okay.
So you're not going to get to 100.
Right, exactly. Excellent. Well, I don't see any more questions. This has been a really wonderful discussion, Sarah. Thank you so much for joining me today.
Oh, it's been my
And
pleasure. Thank you.
and I'm sure all those who will be watching this after the fact will get so much out of it. Thank you, everybody who attended and sent us questions, because I think they were incredibly helpful. I'm seeing one last question that says, who do you have on your team? You mentioned a dietitian. Do you work with PT for the exercise testing recommendations? What's the flow for patients when you're doing this type of work?
I have an exercise physiologist who works with me, as well as a nutritionist,
Yeah.
as well as my staff, obviously, my medical assistant, nurse staff.
Yeah, that it's so I want to highlight that as we go out, because we also at Genève believe in collaborative care, and we work really, really closely with our dietitians who are on our team, because we can only know so much as a physician, right? And there are people with other expertise that's really critical to a healthy lifestyle, and using that expertise is everything.
Exactly.
So,
And in our clinic, and I'm sure in yours, I mean, we certainly want people to bring in information that they have found, but the web is not curated very well. And
no.
so it's difficult to know what to do and what and when. And so I think having this expertise is at your fingertips is really important. I want to say one more thing, and I'm going to ask Britt to put this into the chat. There is a wonderful article in circulation that says basically rethinking menopause hormone therapy for whom, what, when, and how long. And
Oh,
it's a wonderful review. It's fairly contemporary from 2023. And so I think for those of you who are interested in how to approach patients with cardiovascular risk, this is very helpful.
that is a wonderful reference. I'm going to actually read it myself, because I had not, circulation's not one that pops up in my readings very often.
Really?
No.
Okay, I'm trying to put this in the chat. Is it this one from the AHA?
It is circulation 2023.
Yep, that's the one.
140.
Yep. Got it.
Yep.
Yeah.
Perfect. It is in
Yes,
the chat.
and we will also be including that link, as well as I'll link to the ELITE study in the follow-up email, so people will have access to that in addition to the recording.
Yeah, and this is actually a free article, so you can go even
Fantastic.
you're not a circulation subscriber.
Which many of us may not be.
May
Well,
not be.
thank you again for coming today. I think this was a wonderful discussion. I learned a ton. I hope our attendees did as well, and those who listen afterwards will as well. And I look forward to talking to you again soon.
Thank you for inviting me. Have a good
Take
evening,
care.
everybody. Bye-bye.
Bye-bye.